Umeh, I think you can. Dr. Shodinke, please go ahead.
Okay. Good morning, everyone. My name is Radia Shodunke. Eye Foundation Hospital as well. Welcome to another episode of YOF Clinical Series. And today we'll be taking retinal optical coherence tomography by Dr. Umeh Victor, a retinal fellow with Eye Foundation Hospital Stroke, Kunle Hassan Eye Foundation Academy. So if you have any questions during the course of the presentation, you can note it down somewhere. You can just start writing in the chat box so you don't forget. And let's also try to keep ourselves muted so that we don't disrupt the presentation. Okay, thank you very much. Dr. Umeh, are you ready? Hello?
Yeah, good morning, everybody. Thank you, Dr. Shoduke.
Okay.
All right. I want to thank the YOF for this opportunity to actually contribute. And I would say that this is a big one, but we'll make the best of the time we have. And I want to sincerely thank the organizers, the YOF. I think this is my second time. It meant that the first time was not a waste of your time. So what we are doing today is actually to go through the retinal OCT, optical coherence tomography. And next slide, please. And we're going to, the learning objective is actually, would have some learning objectives, go through the introduction and the part of the printout and down to question and answers. So for the learning objective, I think everyone on this course, especially those that are should be able to describe what the normal retinal OCT looks like, understand the layers and their significance, such that if faced with a pathology, you can put your theory to match with what you expect from the OCT, and also know how the OCT can be used in disease monitoring. So I'm sorry about what I'm about to say, but the images I'm using on this presentation, next slide, please. The images are mainly from OptoView OCT. It's because of the high resolution. There are other OCTs, the common colored ones that really do not do justice to the layers, and I can't really use them to describe. But the OptoView is what I'm used to. That's what we have in our center, and that's what gives the resolution. If you're either in medical retina or vitreal retina, or you really want to see what's going on, you need a high resolution. So this gives up to 5 microns easier resolution. That's the scan speed, the 26,000 scans per second. And there are different scanning protocols, but this uses a raster scan. And those are technologies that the OCT uses. So I know Dr. Abdul took his time, next slide, to talk about OCT glaucoma in the OCT glaucoma discussion. So I'm not going to go so much deep into the basics, but next slide, please. But the major thing is that the OCT is a landmark investigative tool in ophthalmology. So it's the Michelson interferometer. That's the principle. Basically, the OCT sends laser light which is splitted by a beam splitter into two. One of the light gets to the tissue. One of the light is a reference beam that gets to a mirror where it is reflected back. So as the light from the mirror is coming back to the splitter, and the light from the ocular tissue is coming back to the splitter too, they are captured below by a capturing device. So the interference between the two lights is what the OCT uses to make an assessment of the density of the tissue that the laser light was pointed towards. So the terms used in OCT is reflection. So a tissue layer that reflects the light gives a certain interference pattern, and that tissue comes out to be hyperreflective. A tissue layer that could not reflect the light but absorb most of the light comes out as dark, and that is hyporeflective. So those are the key terms. Hyporeflective. Then the other thing we would see how we go about them. So still part of the introduction, it acquires several B scans from the tissue, and when put together by the machine, can give you actually a 3D printout that gives you some form of understanding of the volume in the area. So I've talked about this. Next slide. The next slide, the next one. So, okay. So now, the OCT has undergone several improvements, from the time domain to the swept sub. All these things are targeted at getting higher resolution of the scan, faster scanning per second, and less artifacts. This is because if you put someone on the machine, the longer they stay, the more they will become uncooperative. But if you can acquire fast scans at a shorter period of time with good resolution, it's like buying phones with very good cameras. If you compare the phones that came out in the early 2000s, their picture quality, and the ones that came out this year, you know the difference. It's the resolution, the pixel. Okay, so that's the same thing with the OCT. So there are different machines and different products, and each one has its own parameters, but the thing that is constant across board is the retinal tissue is constant across board. So imaging it, bringing out patterns and showing changes occur by different means, by different machines. So a note of caution is that the OCT is not an ophthalmologist. So it's not from OCT to history and examination. It's from history examination. OCT is an investigative tool. So you, the physician, you, the ophthalmologist, you are going to interpret the OCT on the basis of the history of the patient, the examination finding, and in most instances, you must, as a must, have a fundus photograph, because your fundus photograph will guide what you're looking out for in the OCT and where you place the OCT and what you intend to do there going forward, because several conditions, macular edema, for example, can be from anything. So if you see that on the OCT is a differential. So you have to put the accurate differential that's presented in that way as your diagnosis. It could be diabetic macular edema, it could be central retinal vein occlusion, it could be uveitis, it could be ROP with a macular edema. So the OCT does not teach you the science. You only use the OCT to verify what you already have an inkling as to what your diagnosis and differentials could be. So just I put this time domain and all just for completeness. So in the time domain, the idea is that what I described earlier is just a time domain. Is what it gets is an A scan. The interference is over time. So the mirrors have to move. So the light source will generate an interference pattern. But this time domain has a lot of noise. We call them artifacts, and it's slow. The scans were 400 A scans per second, but they were the deal breakers. They were the first ones that came into play. So they opened the world of opportunities for which the next ones came in. So the spectral domain can also be called Fourier domain. The idea, what changes it? Next slide, please. What changed the whole thing is the introduction of a spectrometer. Okay, so the beam is displayed by a spectrometer, and the interference between the reference beam and the reference beam and the sample beam, that's the beam coming from the eye, going to the eye and coming back, is picked up by a detector. So those happen simultaneously. That makes for faster scanning and for less artifact and for good resolutions. So it can scan up to the speed of 18,000 to 70,000 A scans per second compared to the time domain, which is just 400. Okay. So the idea of getting a faster scan is that the patient can move their eyes. But if in a second you can get 70,000 scans, if a second of the patient's cooperation can go a long way in giving you what you really want as a physician. So the swept source next, yeah. So it's the next phase. Most of it is experimental there, but it's not yet common in the market. The speed is higher. The speed of the scan is higher, and then the artifacts are also smaller. So the light source is swept in wavelength, and the interference pattern is detected on a single or multiple receivers functioning at the same time. So you have a lot of information going in. So let's get into the practicals. So next slide. What I intend to, the understanding I intend to make available is that if given an OCT printout, what should you do? Where should you look? And what would you be expected to know about it? So this is equivalent to every other investigation in terms of a few parameters like the CVF. If you get the CVF, you look out for the patient biodata, name, age, sex. So all these are also in the OCT. The name of the patient, the age, the sex, hospital number, ethnicity. OCT makes room for doctor's name, the operator's name, then the disease, meaning that in some instance, you're expected to have had a diagnosis or a differential diagnosis before sending the patient for an OCT. So if you have a young child, had ocular trauma, blunt ocular trauma, you examine, everything is fine, but you look at the retina doesn't look as pink as it should, especially towards the fovea. You're already thinking about something. Okay, what could have gone on? And his vision has gone down. Let's say vision in that eye is 624, the other eye is 6.6, and is not a patient that has a refractive error. You have a different thought compared to having a 50-year-old diabetic that has been diabetic since he was 42. That's 8 years. And he's presenting with reduced vision, media is clear, and then the retina, you look, it's more like there are no new vessels, there are no bleeds, macula looks a little bit swollen, and you have exudates around the macula. So your thought is different. You won't just say, oh, it's retinal OCT. You already have a thought of, oh, this could be diabetic macular edema in the second person. In the first person, you say, oh, this could be Berlin's edema. Let's just confirm. So you have a pre-investigation diagnosis. So let me put, next slide. So this is a map. This is a printout of a patient. So I'm going to be pointing out some things on it. So on your top left, you would see patient. I had to clear that out. That's patient name. That's top left, topmost left. Patient name, the physician, the operator, and the disease. So those are meant to be filled. So on the middle, topmost part, middle, you see, if this is from your own hospital, you put the name of your hospital and your phone number. That's for identification. Then the topmost to the right, you see the date of the examination, the date of birth of the patient, the ethnicity of the patient, and the algorithm, that's the version of the machine. The age ethnicity is important because several parameters of the retina differ according to ethnicity and by age as well. So what you may call an atrophy in a 30-year-old, you may not call an atrophy in an 85-year-old. So the age comes in handy. Ethnicity, you have to put the descent of the person. It's true that most of the normal database reference, the normative database of most machines are from Caucasians and African American descent. But those are used to calibrate the machines to give it a thought of what is normal and what is abnormal. So if a Caucasian walks into your clinic and you have an OCT done, you have to change it to Caucasian. So for Africans, they generally use the data from the African American population, which really do not represent us fully. And that calls into thought we having our own data for these machines, okay? Now, the first image to the left is the retinal map. You can see clearly written retinal map. The first image there is the image of the retina. It looks more like a red-free image. So in some machines, they will write SLO beside it, telling scanning laser ophthalmoscopy. This also, some people call it an enforced image, although this is not clear. But what is certain on this image is if there are two arrows, one pointing downwards and one pointing to the right in this image here, and the two of them are meant to meet at the fovea, at the center. So where this comes in handy is that if these lines are moved superiorly, inferiorly, nasally, or temporally, the printouts, the image gotten would be different. So the laser for macular lasers is meant to be centered on the macula as much as possible, on the depression, on the fovea itself, okay? So that is gotten by telling the patient where to look in the machine. If you've done an OCT yourself, when you're looking into the machine, there will be for the macular images, there will be a light giving, okay, look at this light straight ahead. So the technician makes sure that the light is directly on the fovea. The two lines intersect on the fovea before the image capture is done. So that's also one of the things you should look out for. If you're given an image that the intersection of the lines are not on the fovea, then you may make a wrong impression of the diagnosis. But that also comes into play saying you should be ahead of the game. You've examined, you have the history. So if, for example, you think a patient has a macular hole and you did your Wassermann test and it gave you the sign and it comes out positive, oh, the line is broken, and you could look on the at the fundus on the slit lamp, and you see the break in the macula, and you get an OCT that looks all fine and all good. You should look for where the lines intersected and probably send the patient back to the OCT for another test. Some OCTs allow you to come in and move the lines. As you move the lines, if you get it correctly on the fovea, you would see what you are actually looking for. And that's about that. So below that is the retinal map itself. That's the two, how do I put it? The two gray pictures, one on top of the other. So that's where we'll give most of our concentration today. So you're meant to see these images are two, but they are the same image of, they are different images of the same thing. One is taken from left to right, and one is taken from up down. So I don't know if it were enlarged further, you'd have seen the arrow. So I want to give out some few things that you look out for on this. First of all, you can decide the eye of the patient just by looking at the image. So this bigger, wider map here now, if you look out, you see, okay, don't worry, when we get to the bigger pan, I'll use it to explain. So the green map that has yellow, something like a round yellow image on it, and then the pink lines is the thickness map for the retina. So what the major thing about the thickness map is that it's taken from the thickness of the retina, and the color code, although some color code may be false, but this is not false. So there it is graded by the color you see. There's a color pane to the side of the green map that has something like a yellow circle. So the color pane, the central part of it is meant to be the fovea. The yellow mark you see is the perifoveal and the parafoveal regions. They are described. I would describe that as we go. And then to the right, to the topmost, to the right, the second line, next to that is the thickness of the different parameters. I can tell you superior hemisphere, inferior, and all that. So lower down, the all green map, squared map, is the normal database reference map of this patient. Okay, to the right of it is the EDTROS foveal sectors. There are 9 of them. The most central part is for the fovea. So the areas, the immediate circle around the most central part is the parafoveal. The next circle around it is the perifoveal. So the other things to look out for here is the signal strength of the test. If you go up below the name of the hospital and come down a bit after the black covering there, you'll see a letter there, signal strength. The signal strength in this patient is 71. So usually tests that have signal strength less than 50 are thought not to be reliable. Okay, so if the media is clear and the signal strength is not up to 70, it's not up to 50, it's thought that if you get a signal strength better than that, that will be fine. However, you have to put this in line with your patient. Several patients may have fixation difficulties, okay, and that may make the scanning long, tiring, and the signal strength may actually be poor. So at this point, you have to put both the history of the patient and the examination finding together while making your decision. All right, so the next slide. So the interpretation of the OCT could be quantitative, it could also be qualitative. So quantitative is that you're looking at the ability of the OCT to measure thicknesses. So different machines have their reference planes, and most would choose the ILM and the RPE as their reference plane to measure the thickness of the retina, of the neurosensory retina. So then the qualitative part is seeing the markers that represent the different layers of the retina and their condition. So if a line is meant to represent a part of the neurosensory retina and the line is absent, you know that, okay, it's a qualitative interpretation. Oh, this line is meant to be here, but it's not here. Or this one is meant to be here, but it's also not here. But when you go quantitative, you're thinking, oh, this retina looks thicker than it should be. This area is thicker, something is going on here. So both of them are fit into the interpretation. So next slide. So I've put in the retinal map that is normal. Next slide, please. And I would explain a few things, and I'll give a few guidance. So first of all, if this is, I've removed the patient name and or the biodata and or date of capture because I had to crop this image, so protects the patient. So, but the first thing you look out for here, apart from those biodata and or, is the signal strength. Signal strength in this is 74, so this is acceptable. Okay, that's the first part. Now you see the retinal, after the retinal map, you see the FWACS image or SLO, as some persons will want to call it. You look for where the lines intersect. Then if you go to the thickness map, you would see something strategic there. The lines did not really cross at the fovea exactly. Look at it. You see the yellow dots there. The lines are meant to cross exactly there. So means that this line shifted a bit, but it's as close as possible, but it didn't cross exactly. So what this means is if you are looking out for something and you get a scan like this, and what you're looking out for is not there, you have to go back and have them repeat the test or move the line yourself on the machine. It can be done. You can move the line till it intersects in the right place, okay? Yes. Now, the parameters have been represented on the square box to the right, to the most right. So everything here is in green. This is because the thickness is being measured against the normative database imputed in the machine. So when it is in the green, it's normal. When there is an increase in thickness, the column moves upward. So I don't know if we can, Dr. Bartu, I don't know if you can put your pointer on the color code bar. Yes, yes. So it moves from the green upwards towards the yellow. If you look, there are tiny numbers beside it. So if the thickness is increasing, the color will change. If this retina was thick, everything would actually appear to be in white. White is like the thickest the machine can color code. So that's up there. Now, when you go to the circle picture to the lowest on the right, that's the ADTRS map. The ADTRS sector represented on the map is the macular thickness map. And a note of caution is that when you have this map, the numbers written on it is more important than the color. So looking at this one now, the fovea itself, which is the 1 millimeter, is 238. So this is adjudged as normal. This is normal. It's usually around 200 to about 250 thereabout. There are figures in Nigerian eyes, and there are differences from one machine to the other. So I would also advise that if you're going to see a patient, even if they have a scan prior to coming to seeing you, even if they have a scan prior to coming to seeing you or seeing your consultant, if you're going to take over management of the patient, please, it's important that you do your own OCT scan. That will give you an understanding of the state of the patient at the time they presented to you, and that will form that will be the data for monitoring. Because when you repeat the test in the same machine, you can run the analysis and be able to compare if there is a progression. So the progression will either be the patient is getting better or the patient is getting worse, especially if you're going to be treating. Okay, now everything here looks good, apart from what I showed you, that the lines meant to cross at the fovea, that's the square box in the middle superiorly. Okay, so next slide.
Sorry to interrupt you, Dr. Umeh. So thank you,
Yes.
Dr. Shuka. He was suggesting using the pointer, but the thing is, Dr. Bature is the one projecting for him. So that's why he had to ask Dr. Bature to go to that particular color code. So he would keep on in between, he would tell Dr. Bature to help him, use the pointer. Then you've used 40 minutes, so you have about 20 minutes left.
Okay, thank you. Let's go. So now part of me believes that the ladies may know better about OCT than the guys, except for guys that have a good appetite and can cook. Looking at this, I know most of us may have had breakfast, but this can actually be used to depict the retina in several ways. If you say take a bite, the machine will take a bite from up, down, and from left, right at the center. The center should be the toothpick above the tomato here. So these other layers are layers of the retina if you put everything together. So it will cut from here up, down, and cut from left to right. And the image that meets the toothpick on each side will be depicted as a macula. So this, next slide. This is the consensus image for the OCT terminology. Now, why this is important is, I'll point out a few things. I may talk about them in passing, but I just hope we'll make very good use of our time. I'll go from top down. It's the same thing as the layers of the retina if you say from RPE down to ILM, up to ILM, that's from down up. Now, in this patient, the precortical vitreous is still attached. So this is a relatively young patient. Now, there's a preretinal space, that is space between the ILM and the vitreous cortex. Okay, now the first layer of the retina to be depicted is the ILM. It goes all the way down from the ILM. The next layer is the nerve fiber layer. So I can tell you that this OCT is right eye. That's because when you have the OCT in front of you and the eye of the patient is covered from you, look for the part of the OCT that has the thicker nerve fiber layer depiction. That if the OCT was taken centrally, so the thicker nerve fiber layer depiction points to the eye. So in this OCT right in front here, Dr. Baturi, you can put your cursor on the nerve fiber layer. In this OCT here now, the nerve fiber layer is thick to the right. So this is the right eye. So I'm going to move some slide backwards so that I can now show you something. Okay, Dr. Baturi, 2 slides back. So now look at this now. If you identify the nerve fiber layer in the map here, that's the second and the third images to the left. You see the nerve fiber layer to this side. See the nerve fiber layer to the other side is thinner. Even the next one is a bit thicker, but the right is thickest. It's thicker than it is. So this is the bundle from the nerve, is a papillomacula. So it's thick. So if you had extended this image to the right, you would have seen the optic nerve. And if you use the first image to the topmost on the left, that first image, the retinal map, you can see where the disc is. The disc points to the hand. So if you have this, you can say this is the right eye, judging with the disc. If you don't have this first image to the left, you can still make the judgment with the retinal map. So this is the right eye, okay? Okay, so let's go 2 slides down, forward actually. So the different layers are here. So I'll leave you to look at it, but all the layers of the retina are represented, but we're going to break them down and talk about them. But I'll point out something very, very important. You have the nerve fiber, the ganglion cell layer, inner plexiform, inner nuclear, outer plexiform, outer nuclear, but you have the Henle fibers here, more towards the fovea. Then you now have the external limiting membrane, you have the myoid zone, the ellipsoid zone, you have the area of the photoreceptor outer segments, and then you have the interdigitation, and then RPE Brooks have choroid. So the macula is devoid of certain layers of the retina. That's the fovea itself, not the macula. The fovea, the foveola, the depression is devoid of certain layers of the retina. That's, you can see from the OCT. You don't have the ganglion, the nerve fiber ganglion, inner layer, inner plexiform, inner nuclear. It starts actually from the outer nuclear, but here Henle, because of the arrangement and the number, multiples. So for macular host, the ILM is peeled, and sometimes different methods, inverted over the hole, or used as a plug into the hole, or peeled entirely for the regions to reconstitute. So that's just to point out that that foveola there is devoid of some layers. Okay, so next slide. So that's the map, okay? Now, these 2 images here, the one to the left is the EDTRS retinal sector, the fovea sectors represented in the map. Then the image to the right is the FWACS image. So when you get through, so I'm taking the components one by one. So we've talked about the printout of the map. Now that's the image of the retina on the map. Then these are the ones that summarize the quantitative aspect of the retinal OCT. So when you have these circular EDTRS areas, I've said, look at the numbers. not just the color. The color is meant to change according to the numbers. But there are situations where the color may change, but the number is still within what you are looking for. It will determine what you do next. But if you run with just the color, if there's a malfunction of the machine and if the database is changed, you would have made a decision without putting reference to the numbers.
Hello, Dr. Umeh.
All right, sorry. Okay, I think I was muted then. So let's go to the next slide. So for the interpretation of the EDTRS map, that's the circular one here to the circular one to your left on the previous slide. There are figures from Nigerian eyes. This was actually a study done in our center. The mean fovea thickness is around 239, and the range is from 200 to 297. And the other thought male much more than female, and it decreases with age. So the one in a younger person should be more compared to the one in an older person. That's what it actually means. Okay, next slide. So I want to describe the outer retina so that when you see it, you know what to look out for. So for the outer retina, there are 4 hyper reflective bands. Hyper reflective, the word is reflection, okay? And there are 2 hypo reflective bands. So the hyper reflective bands are meant to appear as white on that grayscale, while the hypo are meant to appear dark or black on that grayscale. So as we go through it, I'll tell you the importance of each of the lines so that if you're seeing a patient and you're looking out for those lines, you would know what would affect prognosis in the patient. So next slide. So I've put out this image to see if we can try individually on our own to look at this and try to make out the lines. But if you go from the brightest of the lines towards the white arrowheads down are in the choroid. That's not what I'm trying to show here. This is an OCT that actually has enhanced depth imaging. Okay, that's just it. So, but look at the white lines. There are 4 of them. The faintest among them is the one most inward. Okay, the faintest, the one that is most inward, meaning that the one that is topmost among them in the outer retina. Dr. Bature, please, can you move your cursor? Yes, that's the one I'm describing. This is the external limiting membrane, ELM. Okay. The next line, bright line below it, Dr. Bature? Yes. Now, this is called the ellipsoid line. Okay. Some call it a cost line. The importance of this line is on the retinal photoreceptor, the ellipsoid contains the mitochondria. It contains the energy house of the photoreceptor. So if this line is missing, you're sure to a good extent that the vision in the patient would be poor. That's the energy house of the photoreceptor. So it's more like the photoreceptors might be there, but they are not energized. That's the powerhouse of the photoreceptor. Okay. Now, there are now two lines after the hyporeflective, after the two, there are now two white tick lines after that. Okay. The first of the line is the photoreceptor interdigitations, while the thickest and the lowest is the RPE. So, Dr. Baturi, can you point? The thickest and the lowest is the RPE. Okay. Now, I'm going to move 4 slides backwards to the area that has the normal retinal map, the one that has the labelings. Yes. So look at this and look at it very well. The outer retina, those 4 bands in the outer retina, the first and the most faintest, that's the one towards the inner parts. Okay, let's go from out in. So from out in, you look for the RPE Bruce complex. The next one is the interdigitation zone. So in some machines, you may just have 3 lines. If you have just 3 lines, the outermost line is the RPE. Is a landmark line, is the RPE. Okay. Then the next, so from the RPE to the interdigitation zone, the next line is the ellipsoid zone. Okay. And the most outermost of those gray lines, that is the faintest among them, is the external limiting layer. So when I started interpreting the OCT the first time, one of the things I normally do is like a caveat. I just go to the fovea. If you go to the fovea, you just know that after the ILM, you're coming down to the Henle fiber layer, which is outer nuclear layer outside the fovea. So after that, the next line, the next hyperreflective line is the ELM. Okay. The second hyperreflective line after it is the ellipsoid line. Okay. The next one after it is either the interdigitation zone or the RPE line, depending on how it is described. So if you have an event under the RPE line, and an event above the RPE line, what they are called are different. So if there's an accumulation between the RPE and the neurosensory and the other part of the retina, let's say detachment, in neurosensory retinal detachment, you would see how the accumulations happen, whether this is sub-RPE. Okay, in detachment, you move the retina is moved away from the RPE, so the accumulation will be between the RPE and the neurosensory retina. But if it's under the RPE, it's sub-RPE. Okay. Now, the other 2 zones that are hyporeflective in the outer retina, the dark ones, are the myoid zone and the photoreceptor outer segment. The myoid zone contains granules of glycogen, granules of sugar, while the photoreceptor outer segment, as we know, they are just outer segment of the photoreceptor. They are hyporeflective. So 4 lines from out to in, 4 hyperreflective. The word is hyper. 4 hyperreflective lines. The RPE Brooks complex, the interdigitation zone, the ellipsoid or coastline in some terminologies, and then the ELM. They are the 4 lines for the outer retina that are hyperreflective. The 2 hyporeflective lines are from out to in, the outer segment of the photoreceptors and the myeloid zone. The way I usually think about it is that almost everything happening in the outer retina is photoreceptors, the RPE and photoreceptors. So the RPE is there, the photoreceptors would interdigitate with the RPE, interdigitate with themselves, and they have their components. Their components are the myeloid zone, the ellipsoid zone, and their outer segments. Then what separates them from the rest of the retina is the external limiting membrane. So that's the outer retina. So, okay, let's go to the inner retina. Dr. Baturi can slide down. So if down, still go down, sir. No, still go down. So for the inner retina, the rule is that you have alternating bands of hyper and hyporeflective, alternative hyper and hyporeflective bands. So if you still remember, the ILM is the outermost layer. So from there, you can actually count. The hyperreflective bands are fibers. The hyporeflective bands are nuclei. So if we go back to our labeling now, you can actually fix it by how hyperreflective or hyporeflective the area is. So let's start from the outer nucleus on the side. So outer nucleus 1 is hyporeflective compared to the outer plexiform, which is hyperreflective. That's compared to each other. The inner nucleus is hyporeflective compared to the inner plexiform. Then you have your ganglion cell layer that is hyporeflective compared to the nerve fiber layer. So if you write out the regular code we write for the RPE while learning the neurosensory retina while learning their layers is RPE OOIIGNI. So R is the RPE itself, the P is the photoreceptors, the E is the external limiting membrane. The first O is outer nucleus, the second O is outer plexiform, the first I, inner nucleus, the second I, inner plexiform. GNI is ganglion cell layer, nerve fiber layer, internal limiting membrane. If you put this together, you have your OCT sorted out almost. Okay, so Dr. Baturi, let's get to the slide on abnormalities. Just a few, and then we'll check 1 or 2, and then maybe because of our time. Yeah, go down. Down. Okay, so for the abnormalities, you have the consideration when you think you have an abnormality, you have to consider
Dr.
the
Umeh?
location. Yes.
Yeah, maybe Dr. Shodinke can step in. Maybe
Okay,
make
right.
a session.
Hello. So the truth is OCT is a very, very wide topic. I mean, we're even taking only right now, we've not finished, and he had to do an abridged version. So the YOF has been gracious enough to let us have another session so that we can take the abnormalities and everything else on after abnormalities. So I think we can just stop here and we can take questions based on what we've talked about so far. So right now we ended at the normal retinal map. So we can take questions from here.
All right, thank you. So questions, yes, if they can speak.
One of the questions was, don't forget to explain how you could use the scan to know which eye it is. But I know that you mentioned about the 3. I'm saying it so I can also use it to refresh my memory. There was a scan you brought up where there were 3 images. One of them was showing the optic nerve head, and the optic nerve head was on the right side, so that shows that it's the right eye. And then there's some scans underneath. the retinal map itself, which showed the thickened retinal nerve fiber layer on the right side. So that shows that that's the right eye. But I don't know
Yes.
whether there is any other thing you want to add to let us know which eye it is. But I remember you mentioned those two.
So that's the clue. That printout I shared, I actually had to, if the machines have different printout, the economy of the paper while trying to print the images of both eyes on the same paper may not put the first image that shows the optic nerve head. So the retinal nerve fiber layer thickness is the clue to the eye. If the two of the, if you have your map and the two of them are represented on the map, the thicker one points to the eye of interest. The thicker one, yes, go scroll. On this one now, for example, okay, leave this. On this one, for example, look at the nerve fiber layer thickness. This is for the right eye. The nerve fiber layer is represented on the left too, but it's not as thick because this nerve fiber layer on the right is closer, it's coming from the optic nerve. It's close to the optic nerve. So the nerve fiber layer entering there is thicker. So this is the right eye, okay? So there are other questions.
Yes, there's another question. Someone's asking,
Yes.
Dr. Shemba is asking, can you go through the mnemonic on the layers of the OCT again?
Okay, so the mnemonic, okay, now many of us, we took the mnemonic quite trying to learn the retinal, the layers of the retinal, not actually the layers of the OCT. So the mnemonic is RPE, OOIGNI. So I'll explain it. R on the acronym is for RPE itself. The P is for the photoreceptors. Now, however, on the OCT, the photoreceptors are represented by more than one biomarker. That's just on the side. So R is the RPEP photoreceptor. E is the external limiting membrane. The first O is the outer nuclear. The second O is the outer plexiform. The first I is the inner nuclear. The second I is the inner plexiform. The G is the ganglion cell layer. N is for nerve fiber layer. And I is for internal limiting membrane. So RPE OOIIGNI. So I hope that's clear. So is there any other question?
Yes, there are more questions. Someone is asking, Dr. Adegbola Folake is asking that what is the normal signal strength?
There is no normal signal strength, but the thought is that your signal strength should be more than 50. If you're going to use that OCT for an analysis or for data collection for a dissertation, qualities less than 50% may not be acceptable. Then there are some machines that will write scan quality. The ones that write scan quality rate from 1 to 10. They will show you 4/10, 5/10, 6/10. In those ones, you should choose to get scan quality that is better than 5/10. That's like 6/10 and above. So that's it. But the better the quality, the better the signal strength index or scan quality, the more reliable the test is. But once it's above 50, it's acceptable.
Okay, so there's another question. Well, since you showed us the picture of the retinal nerve fiber layer sticking on the right, so this Dr. Bologi Kapimitra wants to see a picture of an OCT of the left eye so that this doctor can appreciate the thickened retinal fiber layer on the left side. Do you have a picture? Do you by chance have a picture in any of your slides that shows
Yes,
the left
I think there are pictures that have both right and left eye put together on the slides. Let me look for one. Yes, there are. Okay, so while we go on, what I want the doctor to take out is, it's not about right eye or left eye. The idea is that if I put a right eye and put a left eye and I mislabel them for you, and I say, this is right eye and this is left eye, can you make it out by saying no, you mislabeled them? So the ones I showed, all the same. I tried to put just one eye on the ones I used to show because of the other maps that I wanted you to have a look at. If I put the two, so most of those maps will not be there for description. But the simple thing is, if you see the nerve fiber layer, if you can identify the nerve fiber layer and it's thicker on the left, that's the left eye. Okay, there is if the slide is still on, there's a slide that has two eyes put together on the same map. I'll tell you the slide number. I think it's number 53. The two eyes are there so that the doctor will see. Number 53, the slide 53. So.
Sorry, there are no slides numbers here. But
okay, keep scrolling. I'll tell you when to. Just keep going down. Keep going, sir. Yeah, keep going. Keep going faster. Okay, even this, but keep going. There's a better one. Keep going. Keep going, sir. Keep going. Keep going. Keep going. Keep going. Keep going. Keep going. Keep going, sir. Keep going. No, keep going, not this. Yes, this one. All right, so I want the doctor to actually, if you can, enlarge this image on your own screen. Now, move to the picture on the left and see if you can identify the nerve fiber layer. You see that it's thicker to the left in this eye. Okay. It's thicker. It's thicker on this eye. If the nerve fiber layer to the left in this eye is thicker. If you go to the right eye as well, the nerve fiber layer to the right is thicker. Although the particular pathology comes with generalized reduction in the thickness of the retinal layers, more so the outer layers we discussed today, the hyperreflective bands. But the nerve fiber layer there on the left is thicker for the left eye, and on the right is thicker for the right eye. Okay, especially for the scan that moves from, especially for the scan line that is from left to right. If you look at the topmost part of the picture, you see the scan line. The one pointing to the right, that's the upper one. The lower one is pointing down. That's the scan that comes from superior down to inferior. All right. I hope I've been able to satisfy that. Okay, so there's a question on the description of the hyperreflective and the hyperreflective layers. Okay, so the clues is